Dear Chair, dear audience, let me introduce you my PhD topic, which is oral health of patients with eating disorders. My name is Adrienn Széll. I am a dentist at the Department of Prosthodontics. My supervisor is Zoltán Géczy, and my scientific methodology supervisor is clinician. My vision is to improve recovery rates for patients with eating disorders, and my mission is to assess oral cavity differences between patients with and without eating disorders. My primary goal is to conduct a comprehensive literature review to identify the oral manifestations associated with eating disorders, and based on the findings, I aim to conduct clinical research to further investigate these observations. The title of my first project is Investigating the Prevalence of Oral Conditions in Patients with and Without Eating Disorders. Eating disorders present a major health concern among young people globally. Recent studies shows that up to 33% of women and up to 13% in men suffers from an eating disorder. 10% of people with anorexia nervosa die within 10 years of getting the disease, and 20% will die after 20 years. It means that anorexia nervosa has the highest mortality rate of any psychiatric disorders. 80% of patients with bulimia nervosa do not receive treatment because these patients usually hide their disorder and conditions. Even though after 6 months, first signs of tooth loss may occur, so it means that the dentist could be the first healthcare professional to encounter a patient with an eating disorder. Here I outlined the oral manifestations. For example, vomiting can lead to erosion, hemorrhagic lesions, or hypertrophic parotid glands. The inappropriate use of diuretics can result in hyposalivation or xerostomia, and extreme diet and nutrient deficiencies can end in cheilitis or glossitis. So my aim is to highlight the role of the dentist to recognize oral signs of eating disorders for timely intervention. So here you can see the question driving my research. It is how do eating disorders affect the oral parameters? The P refers to patients undergoing dental visit. E represents patients with eating disorders. C denotes patients without eating disorders, and O focuses on measurable outcomes like DMF, dental erosion, or, for example, soft tissue lesions. My hypothesis is worse results for oral parameters in patients with eating disorders than in patients without eating disorders. And the clinical implication is clear. Early diagnosis of eating disorders through oral examinations are crucial for timely intervention. Here you can see my flowchart selection. We started with 9,540 articles, and after the selection and the citation chasing, we ended up with 66 eligible articles. Here I summarized my finalized measurable outcomes. On the left side, you can see the outcomes analyzed using mean difference. On the right side, with using odds ratio. And here my outcome measures analyzed using simple mean and ratio. And let me show you my 3 main outcomes. So the first one is the MFT, which stands for decayed, missing, and filled teeth. It's a widely used index in dental epidemiology. The higher the DMFT scores, the worse the dental health. Here you can see the mean difference in the MFT scores between patients with and without eating disorders. We divided the articles into 3 subgroups: anorexia, bulimia, and mixed group. Altogether, with the patients with eating disorder, we had around 800 patients and around 900 in the control. And the result shows that a patient with eating disorder has 2 teeth affected with decay or a filling, or which is missed. My second outcome is dental erosion, which refers to the loss of the dental structures by acid, which can lead to sensitivity or pain. Here I could also divide into 3 subgroups, the articles, and altogether here we had 368 patients in the eating disorder group and 970 patients in the control group. And in the pool results, you can see that the patient with an eating disorder has a 14.3 times higher chance to have dental erosion. And here the salivary gland enlargement, which refers to the inflammation or swelling of the salivary gland, which can lead to discomfort or difficult swallowing. In this plot, we included 5 studies, 5 cross-sectional studies with 127 eating disorder patients and 114 control patients. The result shows that the patient with eating disorder has 8 times more chance to have a salivary gland enlargement. So here you can see the progress of my first project. I am at the manuscript writing phase. So my second project title is comparing the oral health status of patients with and without eating disorders in Hungary. It will be a cross-sectional prospective observational study. Today's eating disorders are becoming more common, especially in the developed countries like Australia, Northern Eastern Europe, or North America, and less prevalent in, for example, Africa or Eastern Asia. As I mentioned, anorexia has the highest mortality rate of any psychiatric disorders. It means that, for example, in the United States, in every 52 minutes, someone dies because of an eating disorder. 80% of patients with bulimia nervosa do not receive treatment because they usually hide their conditions, but the dentist could see it after 6 months. So my aim is that the dentist can recognize the oral signs of eating disorders for timely intervention. So here you can see the question driving our research. Do patients with eating disorders have worse oral parameters than people without eating disorders? Using the PICO framework, P refers to patients undergoing dental visit, E refers to patients with eating disorders, C denotes patients without eating disorders, and O focuses primarily on the dental erosion. And we also would like to investigate the DMFT, the periodontal status, soft tissue lesions, and the oral hygiene. We hypothesize that patients with eating disorder have worse oral parameters than patients without eating disorders. A clinical implication is only recognition of eating disorder. So here you can see the protocol drafting phase or inclusion criteria for the study group would be diagnosis of an eating disorder by a specialist, and the control subjects are confirmed of not having any risk of an eating disorder by EDI2. Exclusion criteria would be, for example, pregnant, patients who are taking antibiotics, or dental professionals and dental students due to their specialized oral health knowledge, so to prevent bias. Exclusion criteria would be patients undergoing dental treatment involving rehabilitation of dental structures and removable partial dentures. So to summarize my project, this study bridges the gap between the dental health and systemic conditions and highlight the dentist's role in multidisciplinary healthcare teams for managing eating disorders. Let me end my presentation with my sister's words. In the coming years, you will be the next academic weapon. Thank you for your kind attention.
Thank you for a nice presentation. Is there any question? Yes, please.
Congratulations. My question would be regarding to your first project. in one of your plots, you've mentioned 3 subgroups, and the last one you've said it's mixed and other. So my question is, what do you mean by that?
Thank you for your question. The mixed means that in these articles, the author didn't mention the type of eating disorder, or the results weren't enough to make subgroups. So I don't know exactly the numbers for example, the bulimia nervosa and for the anorexia nervosa. So they put it together.
Thank you very much.
In your first study, did the studies follow up these patients?
There was one which followed up, but...
and how long was it?
I think it was 20 years.
And did they find any differences?
Yes, the oral parameters were worse after years.
And I have one more question, that if you want to include patients with bulimia, and you mentioned that this kind of patients are hiding, how will you notice that they have this condition or not?
Actually, we have contacts from the psychiatric clinics, and the patients will come from there, so they are diagnosed with this. And so patients with diagnosed eating disorder will come to this research.
Just one comment. I'm not professional in designing clinical trial and indices, but it's very strange that excluding and including patients based on different scales, because you use DSM and ED. So including the disease was you use a different scale than for excluded. I think
it's because DSM is for diagnosing the disease, and ED2 is diagnosing the risk for the eating disorder. So it's not actually the same.
If you decide that this patient will be included or not, that should be based on one scale. It cannot be differently.
Thank you. We will talk about it.
Do congratulate for your nice report. I would step back. What Professor Wag mentioned, that what is the pure? I mean, like as a friendly remark, did you consider to purely just define eating disorder, or in the scientific I don't know, environment, it hasn't been purely defined, or is it defined purely and it's divided after that to subgroups that you mentioned, bulimia or anorexia?
Yeah, it's difficult because the sample size isn't big enough to immediately know which type of eating disorder we are seeing or talking about. That's a good question.
Okay, but maybe we'll clarify some other questions, I mean, regarding your first and your second study. Thank you very much.
Okay, thank you.
Okay, I have a question related to your first project in the first forest plot. Could you go back to that, please?
Up here.
Yes, the DMFT values. How would you explain the relatively low amount of difference between as related to anorexia and bulimia nervosa in terms of DMFT values? What would have you expected?
Actually, the bulimia's main symptom or habit is the vomiting. So maybe the vomiting, the erosion can be a big difference. So this is the main habit which differs from these two subgroup. I think it's the
yeah, and we look at the erosion, then it's clearly visible that there's a huge difference in the next side, I think. But in terms of DMFT, what could be the reason for that?
Yeah. So they vomit, and it makes erosion on the teeth, and there is more loss of the dental structure, and we can see less cavity. So there is less dental structure and less cavity. So maybe in this number, so the decay, the number of the cavity and decay.